So I would invite Dr. Vinay Mukhekar. He is leading the Medtronic Diabetes Medical Affairs for the Indian subcontinent, and he is here to present the article from Diabetes Care, April 2021. So over to you, Dr. Vinay, sir.
So I would like to thank you, Dr. Mayur Patel and Dr. Yash Patel, sir, for giving an opportunity. And it's a great pleasure to present when Dr. Prasanna Kumar is chairing, or I would say supervising. So, sir, for you, I changed the name of the topic as well, because you said we need super artificial intelligence. And this is, I believe, is going to be about super artificial intelligence. So today's article is Collins OJ. She is the endocrinologist in New Zealand, Christchurch Hospital. And there were many authors, but I just put them under et al. And this article was published in Diabetes Care 2021. The title of the article is Improved Glycemic Outcomes with Medtronic Advanced Hybrid Closed Loop Delivery. And this is a randomized crossover trial. And interestingly, it compared the two insulin pump systems. So what is basically going to do is that, when we are looking at insulin pump, which is available in India, we need to titrate the doses, we need to calculate the doses. So now the time has come where automation can really help, and automation can do the things. So this study basically investigates the performance of advanced hybrid closed loop system. So we are getting almost a step closer to the complete closed loop, but so that's why it's called advanced hybrid closed loop. And it can actually adjust your insulin delivery to take your sugar to closer to 100 or 120, depending on the clinician decision it will do. So it has two factors. It can automate the basal rate. At the same time, it can also deliver automated correction boluses every 5 minutes if your sensor glucose is high. And this is the key aim, or the research question was, can we use the automation to increase time in range? Because in nowadays we don't use A1C as though it is a well clinical proven, but where time in range actually goes beyond HbA1c to actually capture not only the average, which HbA1c talks about, but the overall complete clinical picture. And at the same time, we all want a better A1C, but not without increasing hypoglycemia. So the overall objective was to increase the time in range without increasing the risk of hypoglycemia. And here it was the comparator arm was a sensor augmented insulin pump therapy with PLGM algorithm. So PLGM algorithm is something like our air crash system, which is there in the aeroplanes. So whenever the sensor glucose starts going low, it stops the insulin delivery before it reaches the low point. So it is a kind of predictive low glucose management system. So the two insulin pump systems, one is very advanced versus one is little less advanced. So why is the question, why the study was done? So the recent T1D exchange data says that only 21% adults and the 17% youth achieve desired A1C targets. All doctors or any treating physician don't want to keep their A1C of the patients high, but the biggest barrier is hypoglycemia. So it's a tightrope walk that he needs to walk. So what is the opportunity now? The opportunity is to improve the glycemic control. And the other problem is a diabetes burden, particularly type 1 diabetes patients. They have so much diabetes distress, stress of managing diabetes. So can we reduce this diabetes burden? And that is a patient-centric outcome that this study was looking at. So here we need to look at what are the wish of doctors. What do the doctors think that the patient success with insulin pump therapy? And this was a study which was done in 2012 by Perot et al. It was a multi-center, multi-continental trial, though it was a questionnaire trial, which asked the doctors and patients what is the ideal insulin pump therapy look like. So where you can see, they said that, okay, starting insulin treatment when required, but problem was taking basal insulin every day, taking basal insulin at the same time every day, and taking bolus or insulin, premix insulin as prescribed, and adjusting insulin doses. So you can see from last decade, everybody wants something that we need to give optimal insulin. And that is only possible with automation, because no matter what we do, it's always a challenge to get the right insulin at the right time for the right food, as well as whenever your physiological basal increases or decreases happen. So here I just wanted to first show you exactly what does it work. So for example, when your sugar goes increasing, your basal rate will be automatically increased. At the same time, when you will eat the food, there will be small boluses also will be delivered. And when your sugar is going down, your insulin will be stopped. So this is how this entire automation will be done. And this basically will be automated not only for basal, for also for the bolus. So when the research design was looked at, so this study is a dual center, only 2 centers in New Zealand were there. It was a randomized open label. And basically it was a crossover study where the 2 arms were crossover between the advanced hybrid closed loop and the sensor augmented pump therapy. And it was not like they were admitted and you were strict tighter condition to live in. They were like, the patients were in the home, they were doing whatever they were doing earlier. So it's called like free living conditions. The age group was pretty big, like 7 to 80 years, though the total number of participants were 51. But the age group was pretty, I would say, big in size. And the primary predefined objective was that to evaluate the difference in time in range. And here time in range was defined as what % of the time patient spends in the range of 70 to 180 milligram per deciliter. So that is a percentage value, and that was compared between the advanced hybrid closed loop, which is automated, versus the a sensor augmented pump therapy. So nowadays we are all familiar with this, because nowadays we don't talk much about A1C, which is average. But what is the beauty of this is that you can see that the sugar values have gone down compared to the advanced pump that is available in India, which is a PLGM. It is significantly down, and particularly the night time you can see there is a beautiful difference that can be seen. Though with every new investigational devices or even with new basal insulins, you can see the pronounced difference is always seen in the night time, because that is where there is less interference. And that is where you can see here there is a big difference all over. And these are all the various graphs of the age wise. So like 7 to 14, 14 to 21, 21 and onwards, and everybody together. So what basically it does is that it actually help you to improve your time in range significantly. Looking at the weakness, yeah, the study, the 2 arms or the 2 phases of this study were 1 month each. So it's a very short duration study, 2 weeks here, 2 weeks there. So total 4 weeks. So again, we can't generalize this for how will it go. There are other studies which are being conducted, which are a little longer term, but this study basically look at a short term. So this is more of a concept testing trial. And the comparator is insulin pump therapy with 24-hour CGM, which is very a small population in India as well. So when you look at the time in range was 72.6%. And now if you look at an article by Roy W. Beck on correlation between HbA1c and time in range, a time in range more than 70% correlates to A1c of less than 6.9. So now you can see less than 7 was always a dream. This can be achieved, or this can be achieved with the automation, and where this automation can help you a lot. And this was more than 12%, which was the earlier generation pump, which is amazing. But the important point is nighttime time in range is 89.7%. Now imagine, we are not talking here average, we are talking of time in range. That means your patient will spend 90% of their time or 89.7% of the time between 70 to 180, and which is amazing. And advanced hybrid closed loop is with automated basal rate and automated correction is a really a innovation that to look for, and it will give you better time in range without actually increasing the hypoglycemia. So that is where I feel is a power of technology that can come into the picture. So I can stop here. Thank you. We'll be happy if any questions.
Yes. Thank you. Thank you, Dr. Vinay, for getting this article and to showing the expertise what we deal in the insulin pump. And like you mentioned, the time in range is a concept where plenty of our people know around that almost 70% is corresponding to the 7% of our HbA1c, and 70 to 78 is like 6.3% of A1C where we look for. So this article is based in and we have almost 59 to 60 people. Okay, so 60 people have completed that, and that duration is for how long? How long they had been printed?
So 4 weeks is the duration.
Yes.
And before that, there was a run-in phase of 1 week each. So where the patients were given trained on these devices and all. So that's where is the though it's a 4 week duration study. Yeah.
Yes.
Not like
How do you see it will influence on Indian perspective, and especially in type 1, as well as we use plenty of pumps in the type 2 as well as those who are long standing and higher insulin requirement.
Correct. So I think the right selection of the patients is really key here. If you look at even the inclusion criteria for this study, they didn't include the patients whose A1C was more than 10.
Okay.
They didn't include the patients who had no access to the internet. So they didn't basically look at, I mean, this study at least didn't involve the patients who had started developing a lot of complications. So where you can see, now it will help you to see if your A1C is less than 10 of a patient and who really want to achieve better. I think with technology, the best part is, does your patient want to have a better outcome? And that is the most important criteria where you should look for, like if he is really regular follow-up with you, if he is really keen to have a A1C of less than 7 or even to 6.5. So I think even the pregnant women, which were not part of this study, but slowly they will be involved. But I think that is where this really will be very keen to involve this. Particularly in type 2, there is not very much variability. But if you have type 2 patients with a very high variability, and now we can even define brittle diabetes, where we say if coefficient of variation is more than 36%, then it is a brittle diabetes. So I guess even in these kind of cases, the automated pump therapy can be really beneficial.
That gives me an edge that we know how to use care links in these insulin pumps, and there are limited centers who use care links for the time in range as well as the coefficient variance and the variability to look for. And that's where I would say let's come. This article has a significance to make it to this SM audiences how we can do it in Indian perspective, and what are the pumps we would have available, and what studies we should look for in Indian perspective. That is one of the question for all of us around. Yeah. Is it on the same page, Dr. Prasanna Kumar? Are you on the are you looking into the same page?
Yeah.
Or what is it?
No, I'm looking at the page. I'm looking at something different.
Okay.
When you see the attendance of any conference, it's a bell-shaped curve. You start with 5, 10, 20, 43. Now it is 12 o'clock. It has dropped to 21. So it's a bell-shaped curve. You should also keep in mind for that. But few points. I started using pump in 1985. The first pump I had seen was my fuser pump, Japanese, 10,000 rupees. It has a knob, you have to change it. No basal bolus. Bolus means pressable. One press is 1 unit. That's all what. There was no question of continuous glucose monitoring. There were 3 pumps in All India Institute. Nobody knew how to use it. For 2 years, I used that pump. It was always busy. Now, certain things coming back to this paper. The object is very clear. It is a short term to show time in range is better with this rather than, I think, it's not HbA1c. We don't want that because there are different studies altogether. This study has shown what is unique about it is that all along we use the carb counting. The carb counting is the only method now. Basal, all of us know, 670G, you just fill it up, forget about it, it will maintain that. Now you said it is 100, 120 target. In the pump, do you put the target or do you put the range? My understanding is in 670G, I put the lower one as 90, top one as 140. I'm not looking at a target.
Yes.
As soon as it comes to 100, pump is off. As soon as it goes to 140, pump is on. This is what my understanding. Usually 50% basal, 50% bolus, that's what we need. There are exceptions to it. And no algorithm as these pumps have for boluses. A mother has to still calculate the carb counting and then say for this breakfast, for this lunch, for this dinner, and for this night, this is the done. Now, as you said, probably the ultimate one is, it is an inbuilt one, even for the bolus also. Here, what did they use in the two systems for the bolus?
Yeah. So, sir, as you have already mentioned, and I mean, it brings me to another point with Dr. Yes, like how will it be applicable to Indian setting? I guess in India, you see the carb counting is a very big challenge. And no matter if I ask 10 dietitians to count the carb in same food, they all come up with different things and all. So, sir, that is where I think the new pump with the automation will help you. Let's say have two scenarios. In first scenario, the patient underestimates the carb. So when let's say my carb is 50, but I calculated 20, I will give less insulin. So my sugar may go high postprandial. In that case, as soon as the pump thinks that the sugar is going high, it will give you short autocorrection boluses. So that even if your bolus carb count is wrong, it will help you. On the contrary, if I overestimated my carb, which is very rare because we all underestimate, but even if you give more bolus, then this pump will stop the basal insulin so that your patient will not go into hypo. So I think in our country or our scenario where our patients cannot count carbs, I think this is a very good tool. The only thing where it will stop from being a completely closed loop is where it should have been able to even give automated boluses fully. But here it is only giving automated correction boluses. So patient still has to take 1, 2, 3, whatever units of bolus every 15 minutes before he takes a meal. But the other part is that, sir, is that if he forgets to take a bolus, let's say he doesn't take any bolus, he eats and he goes away. So then again, the pump has an inbuilt capability to give the correction bolus. So I think that is where this technology will be far ahead of whatever pumps which were available earlier. And as you mentioned, sir, correctly, earlier there was a range where the sugar will be corrected, particularly postprandial when bolus wizard calculated. But now here, sir, it is what it is doing is that it is asking you to pick up. Unfortunately, I don't know why, because it's they wanted to do safety first. So when the 670G was launched, it was 120. And a lot of doctors say, no, it is very high. Because people who are going for pump with 24-hour sensor wanted sugar to be less than 7 A1C. So now they have come up with this, which is where say 100. So 120 and 100, the two things are given where if you select a limit of 100, then the sugar will be tried to keep around 100. If it goes high, it will be brought down. If it goes low, it will try to be bring up to that level. So it will be maintained around 100. And I think maybe the next version will come where we can have our 90 as well or 80 as well, where we will try to go as close to physiological in person without diabetes or non-diabetic population.
You told about time in range. Suppose you compare a lot of them, let us say with this latest software, the time in range was better, 89% or 78%. The same people do they have more time below the range? Because I'm worried about hypo. Okay, time in range shows good. What about the time below range? Was it the same as other one or less than that, more than that?
So here the time below range was compared in two ways. First, what was their baseline time below range? So there was a CGM done before they enter into the arm. And it has shown that actually when they entered, there was 2.4% was the time below range. And at the end of it, it was 2.1%. So there was a decrease of actually time below range as well. At the same time, in between, there was I think it was 2.2% in the advanced hybrid closed loop and 2.4 or 2.3% in the SAP. So it was almost similar. So what it basically does, it improves your time in range without actually increasing the time below range. So that is the beauty of it.
The SAP is internally built or it is outside the software of SAP?
So everything is outside. So it's a like
because
pager like thing.
It is not as exactly, because now Indian Institute of Science with our Ramaya Medical College developing an external software. The same your pump is used. They are trying to develop, of course, it is not to this extent, of course. It is just the basal only at that stage to see that there is an external one fab, so that is going to incorporate by Wi-Fi how it should. They have done the what you call in vitro also to see whether it works in vitro. Now they have come to the type 1 diabetic patient to see the external software, whether it can be used to see that it goes, and that external software is incorporated into a mobile phone, and that talks to the pump, and that is going to see. So we're still in the stage of developing. Later on, it can be incorporated within the pump when it becomes truly a closed loop pump without an external. It's a nice article. Thank you. Let me know, Dr. Vinay Kumar, what's your qualification and what you are doing?
So, sir, I have done my internal medicine training in Ireland, Royal College of Surgeons, and then I did my health economics in MBA from Warwick University, and now I am with Medtronic, full time with.
That's what I could sense here from Medtronic. The way you spoke, that you are not a clinician like us, because your knowledge of this one is much more. I was interested in your training, your qualification, and your MBA and working for them. Thank you.
Thank you.
So
Thank you.
he is one of the asset of our team, and he is one of the mentor to make the technology available in India for a longer duration.